Again, thank you all for coming. We're going to go ahead and shift over now to Jenny Kimmel's presentation. Again, it's strategies for working with consumers on an AOT with substance use disorders. And yeah, go ahead and drop those questions in the chat as you think of them, or go ahead and save them for the end and we will address them there. So I will go ahead and throw it over to you, Jenny.
All right. Hello, everybody. Thank you for being here to learn more about the strategies for working with consumers on an AOT with substance use disorders. Next slide, please. Before we begin, I want to talk about how prevalent co-occurring and substance use disorder rates are. In a 2022 data collection survey from SAMHSA, about 53% of adults with severe mental illness used illicit drugs in the past year. And about 44% of adults with any mental illness used illicit drugs in the past year. Only about 21% of adults with no mental illness had used illicit drugs in the past year. So we're looking at more than double the rate of use for those with a mental illness diagnosis. And when we look at the 39.7 million adults in the country that had a substance use disorder diagnosis, almost 95% didn't seek treatment or thought that they should seek treatment. And less than 1% sought said treatment, and almost 5% didn't seek treatment but thought that they should. And these numbers are just astounding and probably highlight an entirely different problem. But I'm here today to talk about strategies for working with consumers on an AOT that have substance use disorders. And I present these numbers to really demonstrate that these individuals are not very much different than the rest of their peers when it comes to engaging in substance abuse treatment. Next slide. The trans-theoretical model of the stages of change provides a framework that assists clinicians in tailoring their interventions and strategies to the individual. This model paired with motivational interviewing is the gold star standard. Motivational interviewing strategies should be implemented in the various stages of change to help motivate the individual to the next stage. There are 5 stages of change listed here. Pre-contemplation, I don't have a problem. Contemplation, maybe I have a problem, but I don't want to do anything about it. Preparation, I probably have a problem and I'm thinking about doing something about it. Action, I have a problem and I'm doing something about it. And maintenance, I need to keep doing these things to not relapse and stay well. And I noticed that some people split the action stage into early action and late action. Also, it's important to note that relapse is a part of the stages of change. There will be setbacks for our consumers. The most important thing is to meet your individual where they're at in the stage of change and work towards motivating them to the next stage. And you should be consistently assessing what stage of change a person is in. And I also want to note this model can be applied to mental illness. Next slide, please. And most of you are probably familiar with working with people regarding their mental illness and a stage of change model, but I'd like to start off with us thinking about things in this mindset to help us apply this knowledge you probably already have to the following slides that I have as it pertains to substance abuse treatment. So in pre-contemplative stage of change, the person doesn't believe that they have a mental illness. They say they don't need medications. At this stage, you're probably getting an AOT order, or they might need an AOT order violated for a pickup order. You might be taking these people to the hospital. In contemplative stage of change, they're not believing they have a mental illness, but they're willing to attend their appointments sometimes. They're mostly taking their medications. They're having conversations with their treatment team about why they think they don't need that court order. And they don't need mental health treatment. Preparation, they're starting to believe that maybe they have a mental illness, but they're unsure what this means or what they need to do. They might understand that they need to take their medications, but they really need help developing the insight into their mental illness. And a lot of times you guys are referring to, therapy or FPE or something at this stage to really help them develop that insight. Action, these people are believing that they have a mental illness, they're attending their appointments, they're taking their medication, and typically you might be thinking about extending their order during this time to ensure continued treatment compliance and enhanced insight, or you might be ending it. And maintenance, they have good insight into their need for treatment, and you are not extending that AOT at that time. Next slide. All right, in the next few slides, I'm going to talk about the stage match interventions for these stages of change as it pertains to substance use. If you try to use strategies that don't match the stage of change the individual is in, the client might drop out of treatment, might not follow through with their treatment goals or recommendations. They might become agitated or reactive to your intervention if you try to intervene at a higher stage of change than where they're currently at. So that feedback from the consumer kind of lets you know, like, okay, I'm not where I'm actually supposed to be. A consumer who's in the pre-contemplative stage of change, they're often unable to see that need for change. They have no desire to make a change. They may or may not be engaging with you. So this is going to look like the consumer who uses crack cocaine regularly. They don't see a reason to stop doing it. They like using the substance and the high that they get. No desire to change their behavior. They may refuse to discuss with you anything to do with stopping using drugs. And if you push those conversations, the consumer is probably going to withdraw and avoid you. So a person in the pre-contemplative stage of change, the clinician's goal is to work with the person, to engage them and develop trust and rapport. So the treatment should really focus on engagement and developing trust. The clinician should help the person get their basic needs met, ask questions to try to gain an understanding of the consumer's point of view and beliefs, and they should be accepting and non-judgmental. For a person in the contemplative stage of change, the clinician's goal is to work with the person to help them develop awareness of the problem and increase that motivation for change. So the consumers that's in the contemplative stage of change often has no real changes in the frequency or amount of substances that they're using in the past couple weeks. They may start to have regular contact with their treatment team, and they're beginning to discuss possibilities of considering a change. They're not really committed to stopping use, but they're willing to have a conversation about it. They're often limited in their hope or their ability or desire to change. And clinicians should use this stage of change to help the person develop awareness and increase their motivation. This could be done by things such as going over a pros cons list with the person, using motivational interviewing, providing tons of encouragement, instilling hope, and assessing the person's confidence to make the necessary changes. According to SAMHSA, weighing the pros and cons of continuing to use substances or changing substance use behaviors is a key counseling strategy in the stages of change model. During contemplation, the pros and cons tend to balance or cancel each other out. And then once it goes into preparation, the pros for changing substance use behavior outweigh the cons. So when the decisional balance tips towards commitment for change, clients are ready to take action. So I say this to show the pros cons list isn't a one-time conversation with this person. So what can this look like? My consumer comes in and tells me that they're struggling today because they're really craving their substance of choice. They don't have the money to buy it, and they hate always feeling in this situation at the end of the month. I might use motivational interviewing to reflect back to them that they often find themselves in the position of craving a drug and not having the income to buy it. And that's a terrible feeling to have over and over again. I might ask them what they've done in the past to solve the problem, and they might share some behaviors that they've engaged in to get the means to get the substance and how they hate doing those things. I might reflect that participating in those behaviors goes against their morals, but they feel compelled to do them to get the drugs. And then I might ask them to go over a pros cons list of continuing using drugs. And these conversations kind of start planting the seeds with the consumer for change, but I'm not pushing them to say, you really need to stop. This isn't, what you need to do. Next slide. And then once we get them to the preparation stage of change, the clinician's goal is to tip that ambivalence and enhance motivation and build confidence. A consumer who's in the preparation stage of change may have reduced their substances for the past 2 to 4 weeks. They've identified that they have a need, a desire, and a commitment to make a change, but they're really not sure what to do. They're starting to show an increased awareness for their triggers, and they might be more willing to discuss the impact the substance use is having on their life. At this point, the clinician should help them prioritize their needs and wants. The clinician needs to seek input from the consumer for their own ideas for managing their substance use and should always ask for permission before sharing any information or advice. They're starting to assist the consumer in developing that discrepancy between their current behavior and achieving their goals by using motivational interviewing techniques. And at this stage, you might encourage your consumer to check out an AA or NA meeting just to see what it's about. For a person in the early action stage of change, the clinician's goal is to work with the person to help develop insight and to provide hope and encouragement. A consumer who's in the early action stage of change has reduced their substance use for more than the past month. They're engaged in treatment and they're actively practicing and applying skills. And so the clinician should help to support the person's recovery by helping them build those skills and knowledge, identifying positive social supports, providing tons of encouragement and hope. And at this stage, when I've worked with consumers who are trying to stay abstinent, but had a little relapse, I would tell them it's okay. It's less about that you used again and more about what you'll do next. What did you learn? What can you put in place to prevent another relapse? We're working with the consumer to build them up and learn from their mistakes. For a person in late action stage of change, the clinician's goal is to continue to work with the person to help develop that insight and provide hope and encouragement. A consumer who's in the late action stage of change has not used substances in the past 1 to 5 months, and they're engaged in treatment and actively practicing and applying skills. They're showing that commitment to change. And the clinician should help to support the person's recovery by continuing to help them build skills and knowledge. I continue to help them identify positive social supports and providing tons of encouragement and hope. The clinician might have conversations with the person to anticipate unexpected obstacles and update their relapse prevention strategies. And then for a person in the maintenance stage of change, the clinician's goal is to work with the person to help support the lifestyle change and provide positive feedback. A consumer who's in the maintenance stage of change has not used substances in the past 6 to 12 months. They continue to be engaged in treatment. They're actively practicing and applying their skills. They acknowledge that they need to maintain abstinence in order to sustain recovery, and they're committed to maintaining that change. And the clinician should provide tons of positive feedback to the person on their success and encourage continued use and practice of their skills and strategies. They may start to explore transitioning to a lower level of care and help the person have trust in their own decision-making abilities and take more and more responsibility for their life. The stages are not linear. Most people who use substances will go through the stages in a circular or spiral pattern, moving back and forth through the stages. As individuals progress to the next stage, they often have setbacks, and that's okay. Like I gave the example before, what did you learn? Most people who make progress will not entirely revert back to the pre-contemplative stage of change. And so it's important to repeatedly assess the stage of change your individual is in and meet them where they're at. It is a dance though, because it's very possible for a person to be in different stages of change for different goals. So for example, an individual could be in the action stage of change regarding their cocaine use, pre-contemplative stage of change regarding using marijuana, and the preparation stage regarding their mental illness, all at the same time. And then here's a visual that I got from SAMHSA's tip book that helps to explain a counselor's focus at the various stages of change. So you guys could use that and maybe just, print off that one slide to help remind you. And so as you can see from the previous slides, I use the word motivate and encourage a lot. According to SAMHSA, motivation is what propels people with substance use disorders to make changes in their lives. It guides clients through several stages and the stages of change that are typical of people thinking about, initiating, and maintaining new behaviors. And there's several ways to motivate clients that are effective in treating substance use disorders. The first one that I'm going to talk about shortly is the FRAMES approach. This was created by Miller and Sanchez in 1994, where they identified 6 common elements with the FRAMES acronym. It is feedback on personal risk relative to population norms as given to clients after substance use assessment. Responsibility for change is placed with the client. Advice about changing the client's substance use is given by the counselor non-judgmentally. A menu of options and treatment alternatives is offered to the client. There is an empathetic counseling style, and self-efficacy is supported by the counselor to encourage client change. And if you're interested in learning more about how to implement this approach, it can be found in Chapter 2 of the SAMHSA Tip 35 resource that's at the end of my slides. A well-researched approach to help consumers change is motivational interviewing. And this is the second motivational tool that I want to discuss today. The spirit of motivational interviewing includes establishing a partnership between the clinician and the individual and services. Acceptance refers to accepting the consumer for who they are and respecting them, acknowledging their strengths and values. Compassion refers to actively caring about the person's needs and welfare. And lastly, avocation is where we elicit and explore the motivations, values, strengths, and resources that the individual already has. Motivational interviewing teaches the clinician precise tools to help them achieve these elements, such as using OARS, which is open-ended questions, affirmations, reflective listening, and summarizing. The main goal of the clinician is to evoke change talk. And if you haven't taken a full motivational interviewing course, I encourage you to do so, as using these tools taught works well with MI and SUD populations. There are currently 27 CEU courses on Improving MI Practices website regarding motivational interviewing training, and CMHA-M often provides these courses throughout the year. When thinking about somebody's compliance with the AOT order that includes substance abuse treatment, I encourage you to think about the stage of change that they're in and motivate and encourage them to the next stage of change. Everyone goes through the stages in their own time, quickly or slowly, and it's extremely person-centered. And as long as the clinician is talking to them about their use and trying to motivate them to the next stage of change, they're in substance abuse treatment, whether the consumer realizes it or not. The AOT order isn't a magic wand that puts our consumers into the action stage of change, whether it be for substance use or their mental illness, but it can provide some motivation for them to really look at their lives and have these discussions with their clinician. I've shared with Olivia some handouts regarding the stages of change for her to share with you. And these handouts describe in more detail the stages of change and provide more extensive information for your interventions at each stage. In previous trainings that I've had, I've been told to make sure to stage each consumer, each goal of the consumer at least every 6 months. But for me personally, I would really look at staging them during your quarterly reviews and annually. That's an easy time to remember to do it, and it helps you have that consistent assessment on where they're at and with meeting their goals, and it helps the clinician reflect on what strategies they might use in the upcoming months to help motivate the individual towards their goals, the next stage of change, and compliance with their AOT order. And additionally, it helps to reflect on what stage of change they're in to ensure the interventions in their AOT order remains the least restrictive intervention for the consumer. And these are a list of the resources that I've used and referenced throughout this presentation. Thank you.
Oh, thank you so much, Jenny, for presenting on that material. That is amazing. I will be emailing everyone the handouts and these resources in the follow-up email to this presentation. So I want to open it up to questions that we may have for Jenny about any of the material presented here today, whether it be about motivational interviewing or the avenue of AOT and substance use.
or any other questions you guys might have. We can just open it up.
Yeah. Any questions at all?
Hi, this is Mike Thompson. I work in the Jackson and Hillsdale areas. And I have a question. It's not so much about the presentation specific to the interventions and the treatment and coordinating with AOTs, but it's about confidentiality related to substance use on a petition and whether or not there are any concerns about entering anything related to substance abuse on a petition that's a public document, which would seem to be contraindicated by 42 CFR if you're a Part 2 provider. So have you thought about that or addressed that in any fashion in the past and how you manage that or take care of that?
I haven't really thought about that. I would think that possibly putting it on the clinical cert, which isn't for the public, and would kind of help to address that concern. But I really haven't thought about that. That's a good point. I'd really have to think about that.
Yeah. Yeah, we have taken a stance that we don't enter anything related to substance abuse on the petition at all. So that because it's a public document and could be reviewed by anybody. And it seems to me that that would risk violating the confidentiality, SUD confidentiality laws that exist, which are so much more stringent than the HIPAA rules.
And they are, but then I would want to balance that with thinking about, it is a petition, and to get the person the help that they need. And so, we can petition for substance use by itself too. So I would have to really look at, if there's any exceptions for that, if that makes sense.
It does, yes. Yeah, so I don't know of an exception in 42 CFR that would allow a state to be able to write a law that would be in opposition to that. But it would be, I think it'd be worth exploring at some point in time and getting some more information from the legal side as it relates to that.
I appreciate you sharing that, Michael. I know that you're definitely not the first one to bring up specifically that issue in this space. So I'll definitely follow up on this to get clarity or, to inform this a little bit more.
Thank you.
That's a good question. That's a good question. Any other questions?
I have a question.
Oh, go ahead, Sophie.
I'm just curious, in your experience, what stage seems the hardest to kind of progress to the next, to get them towards the next stage?
Contemplation to preparation, I think, is, in my experience, has been the one that takes the longest a lot of times, because I worked with people for years that are like, yeah, this causes problems in my life, but I don't want to change it. And I can think of somebody off the top of my head that I worked with him when I was a case manager, and now he's working with one of my case managers. It's been several years and he's still in the same spot. So that one I think can be really hard to help motivate to the next stage.
And I can imagine that can be frustrating for the clinician too, when you're putting in a lot of work to get to that next stage. Do you have tips for the clinician coping with that frustration?
Yeah, so just a lot of self-care and reminding yourself that it's, you're doing the best that you can do. And it is really up to the consumer to make those changes. I've had to remind myself that plenty of times with working with these individuals, because it can be taxing. And so like taking that moment afterwards to reflect and remind yourself and kind of recenter your focus is super helpful.
I appreciate those questions. It's important to address how we ourselves navigate these situations, because it can be very discouraging at times. 100%. So now that, we've opened up the questions to any topic, does anybody have any questions, any AOT related issues that they've come across that you just want an ear for?
I did have a question. This is Jen Higgins from Berry County CMH. When you'd referenced like petitioning someone for substance use only, in practice, I have never seen that actually be helpful. So I don't know if anybody has a different kind of experience. I don't know of any locked substance use facilities either. So it's always kind of that mindset of, sure, you could do it, but then what? Inpatient psychiatric may not be appropriate. So where do they go if they need inpatient, but they don't want it? So I don't know if anyone else has struggled with it. It's almost gotten to the point where I'm like, there's no point in doing it, because there's no good treatment option, at least in my experience. So if anyone has any thoughts or suggestions or different experiences, that would be most welcome.
This is Sheila with North Country CMH. One of the challenges that I found in even seeking that level of treatment through the petition is the petition language. And forgive me if this was already discussed, but the petition language suggests that a facility has already accepted the person, which how does that happen without the person engaging in assessment? And that the family, whoever the petitioner notes, the petitioner is accepting financial responsibility for treatment. And again, that's that I have found is a big stopper. There's no guarantee that they can be accepted. How do you put that in the petition? And what family member do we know is willing to take on the potential financial burden if insurance doesn't cover, if they don't have that to cover? So those have been two stoppers on our end from pursuing a substance abuse court-ordered treatment, although the premise of it, we see the value in it, and there may be options for it through our screening group. But we know that there's residential options, like you said, locked ones. I don't know about that. I don't think so. But there are a couple of Redwood, and Pine Red has a Redwood unit that's co-occurring. So there are some, but we definitely err on the side of looking at if there's criteria for inpatient psychiatric treatment with that co-occurring disorder, because the petition as it's set up right now for substance abuse really has some big barriers to even getting that far from what we're finding. And maybe there's a way around it. If somebody else knows a way around this facility has already accepted treatment for this person with a person that doesn't want treatment, I don't know how to go about that piece of it.
No, there are a lot of like barriers. It's kind of like the AOT several years ago before they changed the law that, it in theory it's really great, but in practice it's very, very hard to meet the criteria. But I would say if there was a way to meet the criteria and there was a risk, I would still petition, because sometimes it's not about that whether or not this will work, but sometimes it is about the paper trail, and that you're trying to do everything that you possibly could to help that person. Because if something, if something adverse happens, you have that, risk is looking at you saying, well, what did you do? What did you do to stop this? And, um, so sometimes it's about a paper trail too. I've done that with, I recently did that with AOT, where the prosecutor's office wanted me to withdraw my petition for a jury trial because I didn't have, the person never showed to the AOT assessment. And even though we did multiple pickup orders and we tried multiple times, and so my AOT assessment that I had last was over a year ago, and also the timeline of asking for a jury trial, which drags on forever. And I had told them, there's a huge risk on this individual, because of his history, huge risk. And I honestly believe that he is going to hurt somebody, in the near future. And so I would rather see it to the end and go to this jury trial, and the jury say that he is not a person requiring treatment, because I will know that I have done everything that I could possibly do to try to prevent, something from happening. And I have that paper trail, and a clean conscience that I tried everything at my disposal. So just kind of putting that out there. I know that there are barriers for the substance abuse petition that make it to where you can't, use that to your disposal. But
in this case, in that case that you're discussing, how did you get around that section that requires the confirmation that he's been accepted or she's been accepted for treatment, and the financial responsibility piece?
no, I was referring to an AOT, not a substance abuse petition.
Gotcha.
Or I was just trying to draw the line of, like, sometimes if we can get it, if we can check the boxes doing it, even though, because the original question was, what if you know that it's not going to work, right? So I was trying to say, try anyway, just so then you tried everything. Haley, did you have a question? I saw a hand.
Yeah, just kind of going off of the same thing. One of the issues I run into a lot on the inpatient side is kind of the enforceability of some of the components of an AOT. So like, if substance abuse treatment and testing is included on someone's AOT, a lot of facilities or treatment programs won't accept someone who is not there voluntarily. So, as a facility or even as an outpatient provider, one of the things that we kind of struggle with sometimes is, how can that portion of the AOT be enforced? And then also kind of what, Jennifer and Sheila were saying is who's paying for the treatment if the person is agreeable to going, and especially if the person's not wanting to go, but their AOT says they need to go. How do you kind of mitigate that?
So I have my case managers providing, motivational interviewing for those stages of change to say that, somebody is there. And if I can get the person at least to the contemplative stage of change, where they're like, okay, well, I have this AOT order, so I think I need to do something, but I really don't want to do something, then we're looking at like maybe AA meetings or NA meetings. We're trying to connect them to maybe peer support services that our peer supports in Genesee County. Several of them have co-occurring experience. So, we're not necessarily jumping to, you need to be in substance abuse therapy. You need to go to a residential place, but we're trying to, more meet them where they're at, and trying to provide those interventions at that stage, and then hopefully, we plant enough seeds and we can help, move them along to the next stage. And it does get tricky because we do have, some people that, psychiatrically they're stable, but with their substance use, they are not stable. I have an NGRI consumer that, substances were directly affiliated with his NGRI offense. But he's taking his medication psychiatrically. He's stable enough. He does not need hospitalization, but he keeps using substances. So it's like I feel like my team is constantly having like these conversations of, okay, what's next? What can we do? What can we do? And we're trying to, figure out plans to support him and not using so he doesn't, reoffend in the community or something like that. And it's just a constant dance of, trying to provide those interventions and, follow the court order and keep the community safe, and also, meeting the consumer where they're at, motivating them to the next stage, constantly having those conversations about, what's happened in the past, and trying to help them, at least mitigate the risk. It's tiring.
All good questions. All great questions. Thank you, everybody. Does anybody have any other questions?
I will add too, for our team, we do have our wonderful judge that will do status conferences for people. And so if you can get a good relationship with your judge and talk them into doing those status conferences, those have been helpful for the individuals that will really be impacted by that black robe effect. Because then, you have somebody that, they have this AOT order. Maybe they never even went to the hearing because they don't have to go, right? And then they have a small slip up, but not enough that you're sending them back to the hospital. But then now I have to go in front of the judge and answer to my behaviors and tell her my plan to not do that again, and things like that. So we use that intervention a lot in Genesee County to, help motivate the consumers for the change by using some of that black robe effect.
May I ask, I'm not sure the most eloquent way to ask this, but have you always had an amazing judge, or was that a relationship that you had to develop? And if you did develop that, like what are strategies in developing that relationship?
So Genesee Health System as a whole has had a good relationship with the judge because she was doing our mental health court for a really long time. She's been on the bench forever. But I did have to, when I started the program, I did have to gain her trust and, create that relationship with her. She was open to the idea and said, okay, we'll try it out with a couple people and see how it goes. And we really had to gain her trust that my team are, competent and they're working hard, and, we had to build it up from there. So just starting with a few, and my judge has been on the bench for, I don't know, over 15 years. And so she knows a lot of the people too. So picking some people that she was already super familiar with, where she, was helpful too to start with. Cause it's like, oh, Jenny, she's oh, I've done this song and dance with Jenny again, like before, but not in that capacity. So yeah, let's bring her in and have that conversation, you know. And our judge she can give the tough love just as quick as she can give that encouragement. And you know, she's elderly, so it's almost like a grandma. You know, you got to go to your grandma and tell her I messed up, or you know, and you get uh that feeling of just disappointment. And so I think that that helps too, is just her personality.
Yeah, that's great. Great answer. I see that Charles asked a question in the chat here, but real quick, before we answer that question, I'm curious if you could utilize your show of hands. Who works in a county where they feel that the probate judge that they work with would or does hold status conferences, or they would be confident that that your judge would do that? Okay, it looks like Michael raised your hand. Okay. Great. Okay, that was like completely out of curiosity, because I know it has been expressed in this space as well, a desire to have status conferences, but you know, coming across barriers in that process. So Charles asked a question: how do you deal with deferment, especially in Macomb, when you know that client needs help and has not followed the order when they left the hospital?
So that's really hard, and I've been advocating for some changes for the deferral process, because after they get out of the hospital, if you want to submit a demand to get it changed to an order, you have to have a doctor show up. And a lot of the time, those doctors that did the certs in the hospital are not willing to show up. So working diligently to secure a new AOT assessment with a doctor is typically what we're trying to do. And following them closely, and if they need a hospitalization, doing the demand with request for pickup. So then we can possibly have the hospital do it, but that has to be you know, you have to be confident that they're going to meet criteria for hospitalization when you submit those, because you don't want to submit a demand for hearing and then they aren't hospitalized and a hearing gets scheduled and you don't have a doctor to show up. So when I train my staff, I tell them at the beginning, like, this is all a chess game. Like, it's really like, you know, we have every chess piece has rules that you have to follow, and depending on what the consumer does is going to, you know, determine what you're going to do. And so just and staying within the rules of, you know, the mental health code. And so it is, you know, sending my team, you know, I schedule an AOT assessment with the doctor, and if they don't show up at the office, my team, like, or if we don't think that they're going to show up, my team's going out there and knocking on their door at the same time to try to have that appointment be a telehealth assessment. In our county, our judge will often allow us, if like if I showed up at my consumer's door with the doctor on video and the consumer answers the door and I say, hi, you know, Dr. K wants to talk to you. And the consumer says, I'm not talking to Dr. K. Screw you guys, and shuts the door. She'll allow us to still, you know, testify on that with a chart review, because the face-to-face occurred, even if it only lasted, you know, 15, 30 seconds. So we try that. You know, we try calling them on the phone to try to do it over the phone. We'll try, you know, asking for the pickups when it's needed. But for the deferrals, I would say that it's very difficult.
Great. Thank you, everybody, for your questions. Just want to throw it out there one more time. Does anybody have any final questions before we wrap up here? Okay, great. Well, again, thank you all so much for carving this time out of your day and showing up here in this space. I always find it so fruitful. But at the end of the day, what matters is that it's fruitful for all of you. So I'm always willing to accept your feedback, suggestions on topics that we can cover. Definitely some great ones have been brought up here today that we will follow up on. But yeah, I just always want to reiterate that this is your space that we'd like to curate to be the most, fruitful for you and your positions. So I don't think I ever said my name. My name is Olivia Cessna. I've definitely shown up in your inbox, but that is my name from the Center for Behavioral Health and Justice. So again, I'm always here to reach out. I will be sending a follow-up email with the content of what was discussed today. But otherwise, I hope everybody has a great weekend and a great Friday and enjoy the sun and stay happy and healthy. Thank you, everybody.
Olivia,
Oh.
before you end, if I can just say one last thing to everybody. For the individuals that said that they have judges that would not be willing to do status conferences or they're not doing them, I just want to say, hold out some hope and ask again later. The SCAO is kind of having some initiatives for more like mental health diversion and substance abuse diversion tactics. And so because the Supreme Court is taking, an interest in this, we all know how long the state and feds take to do things, but hopefully, with it coming more from the top down, the judges might have some different thoughts soon. So just keep trying to make those connections. That was what I wanted to say. Thank you.
Wonderful. Thank you so much, Jenny, for presenting today. And again, thank you all for coming. You take care.